Welcome everyone to our HDR at UCR Research Infrastructure Workshop Series. So we have a wonderful presentation today by Dr. Jenna LeComte-Hinely. And first, before we start, I'll just go ahead and do some introductions. So I'm Pamela Scheffler. I'm a postdoctoral scholar in psychology, and as part of the HDR Research Infrastructure Core, I assist medical students and faculty with their research designs and analyses, and also create statistics learning materials. We also have Dr. Cecilia Chung, who cannot be here today, who is an associate professor of psychology. And we also have Dr. Sam Ying, an assistant professor of soil biogeochemistry, who is the core lead for HDR Research Infrastructure Core. And today we are so happy to have Dr. Jenna LeComte-Hinely, who is the CEO of HARC, Health Assessment and Research for Communities. And she's going to be talking to us today about the HARC dataset. Welcome, Jenna.
Thank you, Pamela, and thank you all for being here. So what am I going to talk about today? First, I'll discuss who is HARC, since we are a non-UCR entity. And then I'm going to tell you a little bit about our flagship service, which is the Coachella Valley Community Health Survey. I'll tell you a little bit about the history and then hit the highlights of our most recent survey, aka the variables I think are really interesting. And then we'll talk about how you can get your hands on the data, what that process looks like, and I'll share about an example of where other UCR researchers have used our survey data. So let's dive in. We'll start with the introduction to HARC. So HARC is a nonprofit organization based out in Palm Desert, and we were founded in 2006. We strive to improve community health, well-being, and quality of life through data. So basically, we're data geeks. There are 7 full-time staff members, which may sound tiny to you, but when I started, there was 3 of us. So really, that's more than 100% growth. I have been with HARC for about 10 years. I started as the director of research, and about 2 years later, I became the CEO. So I'm not the founder of HARC, but I do love it. It's the best job I could ever have wished for. And at HARC, we provide 2 major services: the Coachella Valley Community Health Survey, which we'll be focusing on today, and we also do consulting services for research and evaluation and data analyses. And I want to share a little bit about those. They're not related to our Coachella Valley Community Survey, but just to show you sort of the breadth of what HARC does. I listed a couple of our recent projects or current projects. We're doing a gun violence reduction community needs assessment for the County of San Diego, which is really fascinating that a county is making that effort. We worked with California Institute of Regenerative Medicine, doing some community listening sessions on how you can make clinical trials regarding stem cell research a little bit more accessible to people who live in rural communities. Starting Over is a great nonprofit in Riverside County. We helped evaluate their Housing First program for formerly incarcerated adults that gives people a place to live where they might not have been able to find a place elsewhere. We just wrapped that up, and of course it was a brilliant success, and their residents are so grateful. We also do a lot with UCR, with the Center for Health Disparities. We're about to launch a study of asthma symptoms for people living around the Salton Sea. We did a needs assessment for the California Department of Rehabilitation focused on traumatic brain injury, which was really fascinating. And I just came from the kickoff meeting with QueerWorks and DAP Health. They're doing a universal basic income pilot project where 30 people will be getting $800 a month to use however they see fit for the next 18 months. And we're evaluating how that changes their life. So really exciting projects. So you can see that at HARC, there's a really wide diversity, and the common thread and the common theme throughout is that we're interested in the data that can help improve lives. So let me tell you now, shifting from our client projects to our Coachella Valley Community Health Survey. The reason HARC was formed actually is based in this survey, because Riverside County is a huge county. It's bigger than some US states. And were very different in the different regions. And so people in the Coachella Valley and leaders and organizations were really frustrated because there was great county level data, but that didn't really tell the Coachella Valley story. It was heavily telling the story of people in Western Riverside. And I'm kind of assuming many of you are from Western Riverside, and that's okay. But I'm sure you know it's quite different. So HARC was formed to provide that sub-county level data. And they decided that, okay, HARC would start by assessing the health. We would do a survey. And our very first survey launched in 2007. And a steering committee decided we would do a random sample because that's important to have that gold standard to be able to generalize to the whole community. We'd do it every 3 years. In many communities, such as Western Riverside, you have to be in multiple languages in order to make things accessible. But in the Coachella Valley, you can hit about 98% of the population if you do it in just English and Spanish. We decided that the data should include adults and children and a sample size of about 2,500 people. So our survey content isn't driven by a theory or a model or anything like that. It's driven by what our community members say, I need to know XYZ and I can't find it anywhere else, because we're not in the business of reinventing the wheel. So this is just some of the topics that were on our most recent survey. And with that being said, we do this every 3 years. We try to walk a fine line of asking the same question every year so we can look at the data and see how things have changed and look at trends, while also being sensitive to the idea that sometimes new things are important, they pop up, and some things fall off, because if we added everything that people wanted, the survey would be 3 hours long, and that's unfair to the participants. So it's an interesting balance. So we collect the data, clean it, we weight it to represent the entire community, and we analyze that data. We report it out in a variety of reports. I'm looking around to see if I have an executive report handy. I don't, but we produce an executive report. Pending funding, we also do special reports, data briefs, infographics, and then sometimes we share our raw data with extra special researchers like you all. Most of the people who use our data are other nonprofits, funders, foundations, hospitals, other healthcare providers. The media taps our data quite a bit. Education, both higher education like you all and K-12. Our local city and governments, our county departments. So it's a really diverse group of stakeholders. Using the data, it's used for prioritizing health needs in the community. For instance, one senior center locally uses it for their strategic planning every time they do strategic planning. It's used to develop programs, right? Because it's like, oh, if this is a need, let's develop an intervention to address that need. It's often used to make the case for grants or other funding. It's been used to make policy a couple of times, which we're very proud of. Creating presentations and lectures, writing articles, which we'll talk about later, and doing some trainings. Because I'm a nonprofit, I'm always focused on other nonprofits as well. And this is one of the ways that our data really shines, right? Because it's one thing to say, hey, this is a problem in our community. Can you please give me money to fix it? It's another thing to say, this objective third-party source says this is how many thousands of people are impacted. Please give me money to fix it. So our data helps make a very compelling case for the need for funding. So it's brought in millions of dollars to our valley and funded things like free HIV testing for all, Meals on Wheels home delivery of food for homebound low-income seniors, mental health counseling in schools for children, transportation for people with disabilities, and so much more. So we're really proud to have been a tiny part of these amazing programs. So now I'm going to briefly touch on some of the data points from our most recent survey, the 2022 data. There are about 150 variables in the data. I will not be talking about all 150. I've cherry-picked the ones that I find interesting or especially unique for this. So in the past, we did random digit dial telephone surveys. We don't do that. We didn't do that this cycle. This is the first time we didn't. And the reason for that is that phone surveys are dying out. People just do not pick up the phone. Our last survey that we did that was a phone survey, it took us 11 months to gather and 500,000 phone calls to gather 250,000 completes. And this is a screenshot from The Guardian that shows you just how hard it can be. This is hiker lost on US mountain, ignored calls from rescuers because he didn't recognize the number. It seems like a farce, but it's actually a true story. And it's exactly why we're not doing phone surveys anymore. So we switched to an address-based methodology. This meant that anyone with a residential address had an equal chance of getting a survey. So that does leave out people who are in group quarters, like prisons or jails, or people who are homeless. So it's not quite fully representative, but fairly representative. And they got the paper survey, a letter telling them what it is and encouraging them to take it, a $2 bill as a pre-incentive, and a prepaid, pre-addressed return envelope. And then we did a reminder a few weeks later. So our final sample size is a little under 2,800 completed surveys, and that's weighted to represent our whole population. So here's some of our adult demographics. We have a little over 330,000 adults here. We've got about 1 in 5 who are living below the poverty line. And for those of you who know the research on poverty, that's incredibly, incredibly low. About half of our local adults live in households with an annual income below $50,000 a year. We have a huge Hispanic population, as you see here. And this is one of those questions we ask every time, and we keep it the same. And that is whether working age adults, so 18 to 64, have health insurance. And we don't ask, we do ask it of everyone, but we looked at 18 to 64 because many people age 65 and over are covered by Medicare. So you can see that we had a really big problem with uninsured rates. From 2007 to 10 to 13, it was just climbing and climbing and climbing. In 2013, 1 in 3 working age adults here had no health insurance. Then came the implementation of the Affordable Care Act, and that dropped like a rock, which really goes to show you the impact that policy level change can have. And then we lost some of that ground in 2019. So I was really curious to see how 2022 would look. And it turns out, that we are doing better than we had ever done before. About 13% of our working age adults are uninsured, which is exciting, right? Made great progress. But it's also a little scary because many of those are likely insured because of the disaster, the pandemic rules that you couldn't bump anyone off of Medi-Cal. Given that that has ended and the state of California and Riverside County are going to reevaluate the Medi-Cal probably in September, October, many of these people who had insurance are likely about to become uninsured. So that number is probably going to change abruptly. You and I all know that it's not enough to just have health insurance. You have to actually use that insurance to go get care. And so we asked people, where do you usually go when you are sick or in need of healthcare? And this is important, right? Because you want to have a continuity of care. It's best if you have one doctor, you go to them, they know your medical history, they can see if something has changed and something's wrong. We don't ever want people to get their usual source of care at the ER, right? The emergency room is not a place for usual care. It's a place for emergencies. Unfortunately, you can see a decrease over time in the percentage of people who said that they get their care at a doctor's office, although we had a nice little uptick in 2022. But encouragingly, the amount of people who said that they go to the hospital or ER for the usual source of care dropped for the first time in 2022. So that was encouraging and exciting. Unfortunately, it didn't drop uniformly. When I divided this up by poverty level, you saw that for people living in poverty, still about, I think 12% say that the ER is their usual source of care. So for people who are low income, it looks much different than people who are high income. There's been an increase in people using urgent care as their usual source of care. Anecdotally, we hear a lot about that is because of the extended hours that people are working full time and they can't get into their doctors during regular work hours, so they go to urgent care after hours. We ask about anything that made it very difficult or completely prevented them from receiving the needed healthcare in the past year. And you can see that our top barrier that affects basically 1 in 3 local adults is the length of time it takes to get an appointment. And that is directly related, in my mind at least, to our physician shortage. There's just not enough providers, and so there's a long wait time. Hours the provider is open, as I mentioned, that's a barrier. Understanding what's covered, I totally get this. I have a doctorate, I'm a health researcher, and I don't understand what my health insurance covers and doesn't cover, so that's substantial. Also, not having authorization and taking time off work. I find this really interesting. This is looking at sexual health, and this is one of the reasons why we, whenever possible, we frame our questions the same as questions that are asked on other surveys, such as the California Health Interview Survey out of UCLA, or the BRIFIS, Behavioral Risk Factor Surveillance Survey out of the CDC, so that we can compare and see how does the Coachella Valley differ compared to Riverside County or California or the nation. So sexual health is one of those questions that we can compare. And what I find interesting is Coachella Valley adults are more likely to be abstinent in the past year than adults in Riverside County or California. But if they are sexually active, they're more likely to have multiple partners. So you can see that here on the chart. Either we have no sexual partners, but then we have a substantially higher proportion of people who have 2 or more sexual partners. And on average, most sexually active adults have had sexual intercourse with 2 partners in the past year. COVID naturally was a brand new topic we added to our 2022 survey. I found this really shocking. 27% of our local adults have never been tested, not even with like a home kit. But of the adults who have been tested, 47% have tested positive at least once. So that gives you an idea of just how widespread COVID has been. We also asked whether they had been vaccinated. And this compares very similarly to the county, in case you're wondering. We asked this question on a countywide survey too. The most concerning is the 10% who are not vaccinated and have no plans to get vaccinated. So essentially anti-vaxxers. So we've got 10% of our adult population who falls into that category. We asked some questions on major disease. You can see our most common that have been our just top 3 for many years now are high blood pressure, high cholesterol, and arthritis. So even if you're not interested in health per se, these are really interesting things just in terms of accessibility. Arthritis, right? Are you making things that people with arthritis can open, or can they open their pills? Can they open their door? That's very important because that affects 1 in 3 of our local adults. Mental health is a huge topic of interest for our data users. About 1 in 5 of our local adults have been diagnosed with a mental health disorder, the most common being depression, anxiety, and PTSD. But we all know that it's entirely possible, in fact, I would say probable, that you have some people who are not diagnosed by a healthcare professional. So we also ask questions like, have you had an emotional, mental, or behavioral problem in the past year that concerned you? About a third said yes to that. And then we look at all of those people, either who've been diagnosed with mental health disorders or who've had a mental health concern, and ask if they were able to seek treatment. You can see here that more than 19,000 people needed mental health care in the past year and couldn't get it. So that's really showing a gap where we hope to have somebody do some interventions. Obesity is still a major problem in the Coachella Valley. 2/3 of our local adults have a body mass index that puts them in the overweight or obese category. We ask height and weight and then calculate BMI because, as you can see, of those people who have a BMI, that means they are highly likely to be overweight or obese. About half of them think they're the right weight. So they are very unlikely to change and become healthier because they don't see that anything's wrong. So that's very always a fascinating thing to me, that we need to start really with education before an intervention can be even remotely effective. We also have a lot of questions about food insecurity. That's very important to our data users. 29% of our adults have spent less money on food because they had to prioritize other basic needs. 14% had to cut the size of their meals or skip meals due to lack of money, and this is a significant increase from 2019. More people are using CalFresh and WIC and food pantries, so hopefully they're less likely to be hungry, but it's still a major problem that requires some serious intervention and has gotten worse over time, likely due to the pandemic and the job loss. These are two new questions that we asked this year, one about racism and the other about intimate partner violence. Racism is definitely more common than intimate partner violence. 1.9% of people have experienced intimate partner violence in the past year, which sounds really low, which is great. But if you think about it, that's still more than 6,000 people who've experienced that. So again, a great intervention point. These are two other new questions we ask about air quality, because if you know about the Coachella Valley, we have some seriously high winds, a whole lot of sand and dust, and the Salton Sea drying up. So air quality can be fairly bad sometimes. And so we ask these two questions about how you would rate the air quality in your own neighborhood and whether it stops you from doing outdoor activities. I honestly was kind of surprised that almost half of the people said it never prevents them, because personally it prevents me probably several times a month. It's just too windy and dusty and hard to breathe. So I thought these were two interesting new ones. So we also have data on children. We don't collect data from the children. We collect data from their guardians about the children. We have about 90,000 kids. The majority are children of color, as you can see here, especially Hispanic Latino. We have a third of our local kids are living below the poverty line, and another more than a third are living below 200% of the poverty line. So serious poverty issues. Almost every one of these children qualifies for free and reduced price lunch. The majority have health insurance, which is good, thanks to Medi-Cal. Every child, whether they are documented or not, is eligible. But we have actually 10% of our local children are uninsured, and that's significantly worse than California as a whole. So again, potential intervention point, I'm not sure why they're not insured. That's something we should continue to study. Fortunately, most of them have gotten a routine checkup in the past year. Just like the adults, a substantial proportion are getting their usual source of care at urgent care. And 84% have visited a dentist at least once. Children are actually supposed to go to the dentist at or before their first birthday. That's not typically happening. They're going a little bit later in their lives, but they are going. We asked the parents and guardians about the vaccination status of their child. And this one was really concerning to me, that 23% said that their child is not vaccinated and they have no plans to get the child vaccinated. So that's 19,000 children that probably will not get the vaccine. In terms of safety, 9% of those parents, guardians said that their children do not have a safe place to play outside. That has real implications for obesity, obviously. This one really surprised me, is that 39% of kids aged 2 and up do not know how to swim, which the reason it's so surprising to me is that pools are just everywhere in the valley. Even, crappy apartment complexes have pools here. Not my housing complex for some strange reason, but most places have access to pools. And so the fact that 39% of the kids don't know how to swim is very concerning and puts us at a really high risk for drowning. Mental health, we asked this only for children ages 3 and up. Very similar to the adults, about 1 in 4 children have been diagnosed with a mental health disorder. The most common being ADD or ADHD, followed by anxiety and developmental delay. And again, similar to the adults, obesity is still a problem among our children. They're doing better than the adults. 55% of them have a BMI that puts them probably in the overweight or obese category, versus adults, ours is like 67%. So that's slightly better, but still concerning. And then when we go to the idea of the perceptions, what really struck me is almost no parents think that their child is overweight or obese. So that has some real implications for parental education, whether they think, oh, it's cute, it's baby fat, they'll grow out of it. That actually is unlikely. If a young child is overweight or obese, they're likely to be an overweight or obese teen and an overweight or obese adult. So it's not just cute baby fat, and it does need to be addressed. And you can't really address these things until you educate the parents about it, because the parents are the one doing the purchasing decisions and the meal planning and the meal execution. So very concerning, and also very interesting. Mirroring the adult findings, food insecurity went up significantly from 2019 to 2022. Unfortunately, 14% of our local kids had to cut the size of their meals or skip meals because there wasn't enough money for food, which is very concerning because hungry kids cannot focus in school. They can't, enjoy a healthy life without adequate nutrition. Okay, so that was just a few of my 150 data points. So now I want to transition and to talk about what you can do with this data. So you can check out our overall report. It's available on our website as a PDF. You do have to take a short survey and give us your email, but I promise we won't spam you. And it's just to understand like the impact of who's using our data. We have printed copies that are available upon request if you're more of a paper survey type of person. So take a look at it. It includes pretty much all 150 variables, and think about what data you might be interested in looking at, and then email me. And we'll send these slides out too, because I know my last name is impossible, and I should have gone with Jenna at harcdata.org rather than have this, but that's hindsight. Hindsight's 2020. So once you decide what data you're interested in, we'll sign a data sharing agreement. Essentially, I want you to agree to engage in proper protection of human subjects. No, there's no names attached to these, but you still need to treat it with respect and caution. And only qualified, trained people should be accessing this data. It includes expectations for both parties, and just a brief description of how you plan on using the raw data. So once it's fully signed, then I send you over the data files. They're currently in SPSS, but if you use, R or SAS or something like that, I can send it in that format. And I'll share the methods and answer any questions that you have, like, what are these variable names? That sort of thing. You can request data from old cycles if you want to look at change over time or something, or if you want to put them all together so that you have a bigger wealth of data, or you can just look at the most recent one. We do ask that if you are publishing a paper that you offer us authorship, not first authorship, obviously, but that we're on there. Publishing isn't nearly as important for a nonprofit like us as it is for academics, but it's still nice to be acknowledged. So let me give you an example of somebody who used our data. Will Porter and his grad student Yanning reached out to me, and they wanted to look at HARC's data. They're both in the Department of Environmental Science, and Kurt Schwabe, who's in School of Public Policy. So Yanning wrote this beautiful article evaluating health outcome metrics and their connections to air pollution and vulnerability in Southern California's Coachella Valley, and got it published. And essentially, her area of interest was that as the Salton Sea dries out, more playa is exposed, and that creates pollution, which is a health concern. And so she wanted to explore air pollution, health outcomes, and socioeconomic vulnerability. So this is a graphic from the article that she created. Basically, the idea that people who are living in poverty are experiencing more pollution and poor health outcomes, and it's a big mishmash of unfortunate situations. So she pulled data from our data on whether or not people had been diagnosed with asthma. She also pulled data from the California Office of Statewide Health Planning and Development, OSHPD. It's called something else now, but I'm going to call it OSHPD forever, probably. That publicly available data set looks at ER visits due to asthma. The California EnviroScreen is another publicly available data set, and so that allowed her to look at pollution levels with two variables, fine particulates and ozone levels. And then she looked at demographics to look at the vulnerability, whether there are people living in poverty, et cetera. And that all came from the American Community Survey, another publicly available data set. So essentially, she used our data and all publicly available data sets to conduct this study and didn't end up having to collect any data of her own, which of course is very convenient in terms of cost savings, time savings, but still learned a lot in her study. So the results that she found, not terribly surprising, that in vulnerable, lower income communities, there were higher levels of the fine particulates in the air, but actually lower levels of ozone. Both measures of pollution, fine particulates and ozone, have a positive relationship with going to the ER for asthma. So if you live in a place that's polluted, you're more likely to be going to the ER because your asthma is kicking up. And the ER visits for asthma is also positively related to socioeconomic vulnerability and demographic vulnerability. So if you live in high poverty, you're more likely to be going to the ER for asthma. Now, this is where she came to me and said, I didn't expect to see this finding, because you'd think that if there are more asthma diagnoses, you'd also see more ER visits for asthma, and that was not true. Our data had a negative relationship with that census data, or with that OSHPD data. So anytime there's higher ER visits for asthma, there was lower diagnoses of people with asthma. And she was like, I expected these things to be very tightly correlated. So we had a great conversation, and my theory really was that if you are lucky enough to have been diagnosed with asthma, that meant you at least went to a provider once because you got a diagnosis from a healthcare provider. And possibly you've gone to a healthcare provider more than once, and you've received some treatment, and your asthma is under control. And this means you don't have to go to the ER. You can go to your regular provider. Whereas if you are not diagnosed with asthma, but you have it, that means you haven't gone to the doctor to get that basic preventative care, to get that initial diagnosis. You don't have an inhaler, you don't have a treatment plan, and so your asthma is uncontrolled and you end up in the ER. So this theory sort of explains why ER visits for asthma and asthma diagnoses aren't tightly linked. It has to do with access and being under-resourced. And sadly, many of our communities are very under-resourced and don't get preventative treatment. So this just goes to show you that, yes, you can use our data, but sometimes it doesn't show what you think it might show. But together we can probably figure out why that might be. And it also illustrates the importance of this study that we're doing with UCR, which is going to look at asthma symptoms, not diagnoses, because unfortunately many of our population don't get diagnosed. Okay, so that is my presentation. I wanted to list here some of the adult variables that you all might be interested in that I find really interesting. I didn't do one for the child survey because by training, I am an industrial organizational psychologist, which means I focus on the psychology of work, which means I'm not that interested in children. But I understand that many of you might be, and you are welcome to use the child data set too. I just find the adult one a little bit more interesting, and it has a bigger sample size. So it's more robust in terms of what you can do with it. So I would like to chat now about your ideas your questions, anything you would like to do. And oh, do you need to apply for the IRB? No. We went through the IRB to do the study. And so now you can consider it secondary data and you don't have to go through the IRB. And yes, that is magical because I know how long the IRB takes at UCR and it is a long time. So yes, this is simple, easy to use, no hoops to jump through.
That is so awesome. Thank you so much, Jenna. This was a really informative presentation, such a rich data set.
I know I speak really fast and I apologize for that. I've given similar presentations multiple times, which you can probably tell. But I think it's very interesting to see what people from different disciplines have such a different lens that they bring to it than what I have, which is so interesting, like Yenning and Will's study that they did.
Yes, I have a question about the variables. How do you decide which variables to include? And you said that some had been added in the last few years. How is that decided?
Yeah, so it's really hard. One of the things we do, like I said, in order to access the survey, you have to give us your email address. And so one of the things we did was ask everybody that we know has used our data, what variables they used the most, hoping that we could get rid of some of the ones that no one used and, just whittle it down, because everybody's like, I think you should add this and this and this. And nobody says, I think you should cut this. So it was getting really unwieldy. Unfortunately, basically every variable, somebody was like, I used that. And I was like, oh, drat. So I cut the ones that were less utilized by our data users. Of course, that assumes they responded to my questions about what variables they used. I am certain that somebody will be angry with me that I cut their favorite variable. I definitely have it came back to bite me. Like for instance, in 2019, I was like, I don't think anybody uses the variable about whether or not people have been vaccinated for the flu. That's not interesting. And then COVID hit and everybody was talking about vaccination and, tying it to the flu vaccine. And I was like, I can't believe I cut that one. So I added it back in 2022. So yeah, it's really based on what I hope people aren't using. So for instance, like health insurance, this time was just like, do you have health insurance? Yes or no? We used to ask, what is the source of your health insurance? Is it you pay for it? Is it your employer pays for it? Is it your spouse? And I hated that question because it got really mushy. People would just write in like other Kaiser. And I'm like, that's not what it's getting at. It's supposed to be getting at like, okay, well, who pays for you to have Kaiser? Is it your work, your spouse? Do you just pay out of pocket? So anytime there's something like that where we really see like problems in the data, for instance, when I first came to HARC, there was one question that was open-ended, and it was, what do you think the greatest health problem or challenge is in your community? And I hated it because it was all over the place. Somebody said gangs, someone said Obama, someone said geese pooping on the golf course. In which case I was like, wow, your life is really great if the worst thing happening in your community is geese pooping on the golf course. So things like that I like quietly, I'm like, I hate this question. That's gonna go. I was bummed because definitely some of the ones that I'm like, I don't like this question turned out to be ones that people really used, so they had to stay. But the other piece is that some of the ones that are really low frequency, so for instance, in 2019, we added for the first time a question about opioid use, like had you used heroin or somebody else's opioid medication? And it was really low. It was like 2%. And so honestly, essentially that means people are lying because it is a problem. And so we didn't include that in 2022. There is the hope that people will be honest because it's an anonymous survey. And actually, we probably would have gotten more honest answers this time since it was a paper survey, not a phone interview. But anytime there's something like that, like for instance, somebody was like, oh, I need to know data about bullying. And I said, that's awesome, but this is not the place for that, because we're asking the parents or guardians, and sadly, they are sometimes the last to know. So if I put a question on the child survey, like, hey, do you think your kid is bullied? That would be too low. It would probably be, misrepresenting the breadth of the actual problem. The way you should get that data is to ask the children, and our survey doesn't do that. So there have been times that people are like, I really need to know this, and it's just not appropriate for our particular survey. That was a very long response to your short question.
Oh, no, thank you. That was great. Very interesting to hear about that process. And we have another comment from Masume saying it's a great resource for research projects, pilot studies, et cetera, to involve students and residents, graduate students. Yeah, I agree.
And yes, we want them to know that it's here. They can absolutely use it. And I think that's part of why I'm so excited to have this workshop, is because HARC is just, we're data geeks. We're not pros at publicity or anything like that. So we're just like, it's here, use it. And then we get people who are like, wow, this is so cool. I had no idea it exists. And I was like, yeah, I'm really bad at PR. I'm really bad at like telling people that it's here. So I'm grateful that I have this opportunity, and that if any of you know people who might want to use the data set, if you can share with them that it's here, it's free. We want it. Data that just sits on a shelf is useless, right? We want people to use this. Otherwise, has been a waste of time and effort for me, and for everyone who took the survey. So we absolutely want people to use this as much as possible, to make great things happen. We're not trying to keep it all to ourselves.
Great. And I think also too, it's a great jumping off point for CBPR, because although using the data wouldn't technically be CBPR, it can help inform some issues that are going on in the community. And then you can go to that community and discuss further with them what needs to be solved and what could be further investigated.
Yes, I think that's a great idea. Community-based participatory research, or CBPR, is so integral. So for instance, if like I was saying about the child obesity, right? That none of the parents think it's a problem. And I find that so fascinating and so concerning. That could be something that you don't even need the raw data. You can just look at the report and be like, wow, that's a really interesting topic. I'd like to go into the community and ask some of the parents, like, what's the deal? Like, are you concerned about this? Do you want to, do some research on it? This is what our data is showing. Are you concerned about it? How could we work together and to do CBPR research? So it is a very good place to be like, oh, I see an issue. Does the community see the issue? Let's go talk. It's also interesting to me, that our written report that everybody gets is just like high level. A couple times I compared, over time, like you saw with the health insurance. And a couple times I compared, like by poverty, like I said, with the barriers or the usual source of care. But you can slice and dice this data so many different ways. And unless we end up getting funding for a special report, like one that looks at people with mental health issues versus people without, you don't really get to see deep down. But it is really fascinating to use any of those demographics to look at, some of how things vary. Like, what's more prevalent in the LGBTQ community versus the straight community? The ability to do that with the raw data is something that the general public doesn't have. Although I do always say that if somebody's like, we're earning a grant for that specifically wants to help Hispanic girls, can you tell me how many Hispanic girls have mental health problems? I can run that for them really easily and just tell them this is what it is for Hispanic girls specifically. But you all as researchers are are skilled enough that I trust you with the raw data, so you can take a look at it and you can look at those things on your own and explore that in more depth versus the general public who wouldn't know how to do those analyses and might interpret it in ways that would concern me.
Great. Oh, we have another question from Sarah. Is there an opportunity to add psychological variables like how patient people are, coping styles, etc., that could be related to healthcare utilization and health behaviors?
Oh, that would be good. See, this is the problem is you see what data there is and you're like, oh, we should add this and this and this and this. And then before you know it, the survey is humongous. But I think that's a really good question because you're right? I mean, the number one barrier was how long it takes to get an appointment. So why would you bother going? But yes, that would be really interesting to look at coping styles. And we, I mentioned we do other work and we do the client satisfaction surveys for Intercare, which is a federally qualified health center, used to be named Clínicas de Salud del Pueblo. And they have about 15 clinics, and across the board, their patients love them so much. But it's really interesting to see when we're asking like what was good, what was not about your experience. Was it the time that you spent in the waiting room? Was it the time that you spent back in the clinical room waiting for your doctor to show up? And overall, they're just so thrilled and grateful to have this care. But some of the things that do bother them is really interesting to me, like the chairs are dirty. So it's an interesting thing. And one year, for some reason, multiple people said they were upset because there wasn't ice cream in the waiting room. And I was like, you're getting care at a clinic. Why would there be ice cream? I guess one day there was ice cream or something. I don't know. They were sad that there was no longer ice cream. But it is really interesting, like what upsets them, right? And also, you mostly think about like cultural competency of your providers, right? Like, are your providers treating your patients with respect and everything? But you don't always think about that for the front desk staff. I did a lot of work with the LGBT community and they said, yeah, my doctor's fine. They clearly did like continuing education on how to speak to a trans person. But when I present as male, my pronouns are he and him, I have a beard, and the front desk person says, Ms. Jane, please stand, Ms. Jane Smith, and I stand up. It's very embarrassing for me. It's awful. I feel uncomfortable. I don't want to be there. So it's really interesting to see like what those barriers are, right? It can be as little as somebody being disrespectful at the front desk. Oh, AI-based models on this data. I have not. I don't even know where to start. So if you do, I would be interested in exploring that.
Yeah, if anybody interested, yeah, we can explore that area. It's
Cool.
my interest.
Yeah, that is not in my bag of tricks. So I would love to explore that for sure. Okay, well, I was just reading an article this morning. I like to read this blog, nonprofitaf.org, I think. This genius man, Vu Lee, writes about nonprofits, all sorts of things, and he's very, very smart and very funny, which doesn't always go together. And he was promoting this in this week's post, the 50-minute meeting, so that we don't have back-to-back meetings anymore and that you have time for your brain to refresh. And it actually helps with creativity and productivity. So Pamela, I vote we end now, and I encourage all of you to take a 10 or 8-minute break before your next event, because I think it will promote creativity.
That sounds great. I'm going to have to check out that article. Thank you. All right. Thank you so much, Dr. Jenna. And don't forget to join our next workshop, which is going to be on April 25th. It's workshop 5 on basic analytical techniques and experimental design in CBPR. So we'll see you there. Thanks so much, everyone.
Thank you all.